solidarity, but how can you have policies that build that kind of generativity? How can you have incentives for younger people to be able to care? And both in India and China and in Singapore, you've had policies that are, as you can, one second, let me show you this. These are, India has something called the Maintenance of Older Parents Act, which was passed in 2007. Earlier in China, you have something called family support agreements that were passed. So there is this notion that the family is really going to step in to be able to be bound to be looking after older people. And there is this mythology, and this is a museum on filial piety in China. This is the Chinese president's own filial piety shown in a museum. So, and this is the legal foundation for family support agreements that are enshrined in the Chinese constitution. So what we're really speaking of is that you have a joint family, or which is asked to, you're asked, you have an intergenerational family that's asked to look after older people, but it's only a middle-class family that actually has the resources to be able to do that. When you're really poor, as economists show, when you're poor or in terms of famine, you're not an intergenerational family. You actually are a nuclear-based family. You shed older people. When you migrate to urban slums in Zimbabwe or to Mumbai, you actually leave your family behind. And the origins of the Maintenance of Older Parents Act in India was really that there were villages full of older people and younger people who were left behind in the villages when you had urban migrants going away. So you can't look at aging without this migration of youth that is happening when you have villages full of older people and urban slums which have a younger population. So I feel that you really need to capture, even in policies, not only the generational integration, but a social integration, especially of urbanization, which I think is really critical. And that's why notions of a World Cities project, the kind of work that the WHO has done, is really interesting because you need to build those bridges. So to come back to just one last slide, because I wanted to wind up, is that my vision really is that we need to look, just as in when we look at epidemiology and the epidemiological transition, we are thinking of syndemic approaches, as all of you know, in global public health. We're thinking of an epidemiological transition in places like South Africa and India, where people just don't have chronic diseases. They suffer simultaneously with multiple morbidities. You have a South African grandmother who has HIV. She simultaneously has hypertension because she has the pressures of living in poverty, looking after a younger generation of children. At the same time, you also have social challenges of political and structural violence that older people are exposed to. So what I'm trying to argue here is really that you can't look at aging just simply apart from the epidemiological challenges itself. You have to frame it in terms of the syncretic challenges, bringing together biology, social, environmental, and cross-sectoral policy processes. And this is not complicated because actually you have policy interventions to show if you give pensions to South African grandmothers, it deals not only with their sickness, they're also able to look after grandchildren. So there is an intergenerational arch there of support that's happening. And they're investing and providing for unemployed youth who often rely on them. And at the same time, you're able to give, invest in across the generations rather than in one generation itself. A project that I'm going for next week is called Generativity in Urban Slums. I'm working with Isabella Aberdeen, who's based in Nairobi, where we're actually looking at how can older people and younger people be connected in deprived settings like urban slums to be able to see how they can invest in each other. So it's, I think, notions of generativity, and we were just talking about well-being in terms of my early work has been on Ayurvedic medicine. A lot of the older people, when there is no cure, don't even come to a geriatrician at a specialized medical hospital. They will actually go to a traditional healer first. Whenever you have chronic pain, whenever you don't have one pill that can sort out what you're suffering from in your old age, you actually go to be able to do either yoga or you turn to Ayurvedic medicine or other forms of healing. So I feel that the last point I want to make is that we need to look a little bit beyond biomedical frameworks to be able to understand what 80% of the healing that's happening is actually outside the biomedical system. So what do people seek in terms of their day-to-day well-being? What are the nutraceuticals that they consume? How do they look for care and well-being outside of cures? And that's actually one of the key challenges I wanted to highlight both in Asia and Africa. Thank you very much.
Thank you, Kavita, and just terrific. And I think you can see in both of these presentations very different perspectives that the intergenerational piece is really important, that it's the cohesion piece. The family strategy is a subset of the intergenerational strategy. And the complication that Kavita mentioned about younger people leaving the older people behind as they go in toward the urban areas, because that's where the jobs are. What we're seeing in the United States is also a fundamental change in the family structure. You know, families used to, one of my colleagues told during one of our meetings said, you know, families used to be vertical and biological, you know, and now they're kind of horizontal and voluntary. And people are, half the families have divorced. We know the connections of stepchildren to step-parents are less tight. People are geographically dispersed and not all living in the same block in Little Italy, you know, the connections aren't there. The safety net isn't there as much in the United States as it used to be. So this family strategy, this intergenerational strategy is relevant
in both places.
In both sets of countries. Let me give you one further piece of detail on the case of South African grandmothers that Kavita mentioned. This is so striking. Esther Duflo at MIT did this study. In South Africa, when they got rid of apartheid and they gave pensions to grandmothers who had worked in agriculture all their lives and never developed any equity, never owned anything. And many of the family, and they couldn't do it for everybody, I guess. So
no, they couldn't.
In some parts of the country to start. And many of the grandfathers were dead or gone. In the households where the grandmothers got the pension, the granddaughters were taller and did better in school. Because they had more nutrition and they had time to go to school because they didn't have to go out in the field. So this intergenerational pathway is very strong.
But I think what's interesting about that study, which a lot of my students analyze, is also that when you give the same income to grandfathers, it doesn't always translate into growth for grandchildren. Now that's a question.
That's not only for grandmothers and grandfathers, it's actually for most male and female
Yes.
in Africa. It seems that women get
Yes.
aid or the
So gender is actually important really
They are
in
much
this.
more organized in using that.
Yeah.
Much
Thank you.
more
Right.
people spending on liquor or something.
Okay, any other questions for Kavita? Yes.
Right.
You all know that one of the biggest successful factors in aging is the social support.
Yeah.
I was just curious, do you have any text to measure social support?
Yes.
Yeah. It's-
Yes, and we,
How do you measure it?
okay, and so, and it's included in one of the metrics in our thing. And there are questions in the OECD in terms of how many times per week do you see or talk with a family member or close friend? How many confidants do you have? What is it, what's your convoy? And the social scientists have developed very rigorous, valid, reproducible measures of social support. And I think that includes family, but oftentimes as people get older and they move away from their family members, they create synthetic families of colleagues and friends in their communities. And what policymakers can do is they can influence this by developing community centers for older people, where there's an inborn support group or other kinds of activities to facilitate social interaction.
Right, yeah, absolutely. And people even adopt, when your children migrate, for instance, you're in the Philippines and your daughters and sons have migrated as maids across the world, you actually adopt a less able person in the kinship network who will actually do home visits, take you to the doctor. So just the activities itself of daily living are looked after through that kinship network, and the number of times you see someone during the day, to come back to what Jack was saying, is really how many visits do you have? How many times do you see your offspring during the day or during the week? And it's been shown that both African American communities as well as data on Latinos in New York shows basically that they do many more home visits.
Yeah.
So question is, how do you justify from a dollar's perspective of government spending on pure healthcare versus social support? Is it
Totally
really a
correct,
good
yeah.
line?
Yeah, I think it's highly leveraged and very efficient investment. What happens is people, you can get individuals in the community and part of the social network to remind people to go to the doctor, to get them to the doctor's office because they can't transport themselves, to go to the drugstore and pick up their medicine for them. I mean, these are incredibly highly leveraged investments.
I agree, but I'm just curious, how do we justify to the policymakers to make those investments?
Yeah, like Meals on Wheels, and the justification is that if you're malnourished, you're more likely to be sick. This is what 1 day in a hospital costs. You know, and how many meals can you deliver for that? It all comes down to preventing healthcare costs, and that would be the justification.
And I think in my opinion, this is why we have this initiative, because if you're healthy, you won't incur the healthcare cost, and social support is critically important. I mean, I think Jack and Kavita gave a great background, but many of you know that one of the challenges of the elderly is, in fact, isolation, social isolation, right? Or purpose in life. And when you don't have those things, you can see that the health status is much worse, depression, many other issues. So they're all totally interrelated, right? And so I think what I got out of this discussion, of course, is that great social policies going to enable a more productive society, much happier people, and much less draining on our healthcare costs, which is huge, because the majority of our healthcare costs, which is Medicare over 65, and the end-of-life care, right, George, is huge. But I think that what I got out of this presentation, of course, is how complex the issue is. I do want you as advisory council to advise me what we should focus on, because we can't boil the ocean. We're only an academy, right? And so, Kavita, I don't think I have the capacity to tackle some of these issues that you talk about, right? So, and the second issue I want to be clear, of course, is that, you know, if you look around this table, and, you know, people have a certain background. And therefore, I'm not sure, and Jack, you can drive us towards that conversation, how much of these issues can we do, right? Now, that being said, I believe Sharon's going to tell you about the roadmap. Certainly, policy is very important roadmap. You're part of a roadmap group, right? So you can drive a lot of conversation, which means that what we're good at the National Academy doing is analysis, recommendation, advice. So maybe I should take a step back. For those who don't know about the National Academies, our founding foundation was National Academy of Science, which is founded in 1863. And it was, in fact, founded by Abraham Lincoln and Congress, chartered to be an independent academy to advise the nation during the Civil War on what do we do with many issues on policy, right? And over the years, we evolved into 3 academies because of the, you know, concentration of issues around engineering and around health and medicine. So now we're 3. But I think our greatest strength is, first of all, take a topic and take a step back and look at these issues and provide objective recommendation. Right? And that's what Congress wants us to do. That's what the executive branch wants us to do. And so our reports are very powerful. And so in that context, we not only work in US, but we work globally. So this roadmap, what we call International Commission, could get into the larger question of what do you need to do globally, but recognizing the complexity of, you just demonstrated, not only high, low, or middle income countries, but also cultural issues and many, you know, issues of mobility and social issues that we're going to have to end up thinking about what do we do and how can we create a roadmap that can be used by different countries as a sort of framework for policy making. So that you're going to hear a little bit more about this. But the other thing we do so well, there's the thing related, we do so well is convening. We can get really anybody, if you forgive me for being immodest, to come to a table to help us think through any issue. Yesterday, we had a whole day from morning to lunch to dinner with the leadership from Japan, the Minister of Health and his whole team, Deputy Minister, you name it, and our team, the Secretary of Health and Human Services, and this team, FDA, CDC. We spent a day, we, Academy, convened them together, talk about bilateral opportunities. And I can give you many examples. So that's what we can do. And perhaps that's what you guys should advise me to say. How do you get the right people to address some of these very complex issues? I would say that even to begin with, this is an international group, but even to begin with, we have a long way to go in US. So, we do need, and Raul, you lived through this, George, you lived through this, and many of us lived through personal experiences about in US and how they address the elderly. We could be more focused on this issue. So I think this is something we need to kind of tackle as an advisory group for me, recognizing our resource, our capacity where we have the greatest impact.
The system has detected that a minimum number of lines are connected to the
Number one, yes. Sharon, you still there? Sharon? Oh. So thank you, Sharon. We just wanted to be sure you're still there. And then finally, what we're best at, thank you, is actually we are a science-based, evidence-based organization. That's what we do. And when we do policy recommendation, we do bring a lot of social sciences in. We have to look at what the evidence base is. And so we're not an advocacy organization. It's actually totally against the law for us to advocate. So we don't do that. What we do is we take evidence base rather than advocate to advise and drive. So this is where science and biology and comes in. So you repeated, pointed out, biology, social sciences, all this stuff. And I think one of the things we can do so well is to think about how to mobilize that aspect of the equation to solve this problem. Now, how should I put this? I said earlier that longevity is attainable, and we know that. Certainly in the high-income countries, they're totally attainable these days. Recognizing we still have socioeconomic divide and things that we need to deal with. So sometimes I think, can I boil the ocean, or do I need to focus on things that we can do? Certainly in the things we can do, looking at the group here, there are things that we can do that actually can make a difference, even though it may not be everyone. Earlier, you mentioned the issue of lifespan. Totally agree. Every time I talk about this, someone will say to me, if you start this at age 10, you don't have to do any of this stuff. And I say, you're right. But here we are. We have a burgeoning population of over 65 we still need to tackle. And you're likely to get more results faster. But none of these things we talk about should not be considered starting in lifespan versus late. Yesterday when we talk about aging, someone says, what about adolescent? What about this? So I just want to put this into context. As you advise me, you need to kind of prioritize and say, what's your strength? What should we work on first? And so on and so forth, okay? That being said, I think I'd like to turn towards science and technology. And when you talk about science and technology, there's a general feeling, and I just gave a presentation to a Health Leadership Council about will technology drive up the cost or drive down the cost, right? But I would tell you in the area of artificial intelligence, the amount that's being used now in developed countries at almost no cost is unbelievable, right? Drones in Rwanda to give blood supply, retinal scan using artificial intelligence to recognize the degree of diabetic retinopathy in India. So I don't think we should immediately equate science technology to high cost. I think our goal is to say what to bring the best science technology to make a difference, and how can we at the same time, as I talked to your council the other day, drive down the cost and have the regulatory governance framework and the reimbursement framework. I want to say that to get it out of the way so we can focus now on what's possible in science, and then we can always come back, and I'm sure, Ned, you think about this a lot, about, right, how do we actually deliver to everybody? How do you make it affordable? How do you address the equity issue? Right. Okay, so I'm going to give you, it's not even biology 101, it's a primer because, you know, we're dealing with a mixed audience, although many of you are so knowledgeable. Maybe I shouldn't have put it this way, but I'm going to be Marsha's supporting actor, framing up the issue for her being the star to talk about her own research, right? So this is the way I look at it. As you already have pointed out, if we want to look at healthy aging and healthy longevity, there are issues we can do from a policy, social, and other issues. And there's also the opportunity to make a difference in biology or engineering, where we can come in with discoveries and ways we can leapfrog that make people much healthier. And of course, in our life, we've seen lots of those kind of amazing innovations, right? I mean, if you look at in the biomedical area, many other areas, you can easily identify why do we have such great increase in longevity. It's because we know about public health, we have medicines, we have prevention. So in that context, I would say the best way to look at healthy longevity, or one of the best ways, is to look at understanding the biology of aging, understand the biology of how your body, your cells, your tissue respond to stresses, and over time responds to the aging phenomenon. If we understand that, one can make the argument that preventing or reversing the processes of aging would be an important outcome. Now, I said at the very beginning, I'm not thinking about living longer, I'm thinking about living healthier. It turns out that many of these processes of aging, biological processes of aging, both in terms of cell senescence, but the reversal of those also enable not only a cell to live longer, they actually function much healthier, right? So in fact, frequently these pathways do converge. And so that's what I'm going to talk briefly about. So, 101, this is the cell. So the fundamental building block is in fact the cell, and of course the cell that make up the tissue, and tissue make up the organ, then through systems, you know, biology makes up the whole organism. But many of you recognize, of course, that the components, which is by no means comprehensive, but for those who are not familiar with this, is of course nuclear DNA, cell membrane, mitochondria, and cytoplasm. Importantly is the issue of genetics. So I think there's pretty good evidence that genes do matter. I'm not sure what percent it is. You know, if you look at some of the early work on, like Cynthia Kenyon's work, who's now at Calico looking at a worm called C. elegans, and a mutation of a gene called DEF2 caused these worms to die very quickly, caused these worms to live twice as long, and it's not only living longer, but they really are young, youthful, functional organisms. DEF2 turns out to be a very important gene that actually mediates insulin receptor, and it's actually made, therefore, it's very important in the metabolism of the organism. We also know that there are families who live much longer, and they're super centenarians, and so that most of us believe that there's in fact information in the genetics and the coding. And so people like Craig Venter has a company called Human Longevity Inc., where they're looking at sequencing, you know, the genome for many of people who live longer, looking at other omics and putting together all that stuff. And in Japan, they have several families who live beyond 110 that they're using to study these genes. So genes certainly matter. How much, whatever, I think that remains to be seen. But I would imagine you also know that some of the people with progeria have much earlier, you know, aging as young people, which is genetic based. The second issue that's important to consider is epigenetics. And George, I believe Epi from Greece is up on top, right? But I think as around. I think what you hear in epigenetic is around the modification of the DNA, which encodes the genetic material, right, through enzymes, and then there's histone and chromatin around the DNA. When they're chemically modified, like methylation, acetylation, they can control the gene expression. What's really unique about epigenetic is the realization now that may be the integrator of environment and gene interaction. In other words, the environment can influence DNA methylation, probably all had to you anyway, and then in that case, it influences switch on and off the gene. So when people look at diabetes, look at cancer, look at aging, turns out epigenetics may be a very good marker for these diseases, and particularly there's a thing now called the epigenetic clock. So DNA methylation turns out to be a pretty good, someone said earlier about what's biologic aging versus chronological aging. So chronological aging is the year you were born and how old you are. Biological aging is how your body really is. And through some of the studies, Stuart Kim and others, right, that the DNA methylation seems to be a fairly good marker for biologic aging. Although that being said, this Finkelman and myself are trying to get together all the scientists who look at biomarkers